Please welcome. Thank you.
So afternoon friends, it really gives me a great pleasure to be in your midst. I can remember the last time I came in here, this was really I think about 2 years ago, and that time I spoke on asthma. Sorry. So this time it's the other major obstructive airways disease we have to talk about, COPD, which unfortunately I think is a bigger problem than asthma also, and is a much more difficult nut to crack. And in some ways it is one of the most important preventable diseases in the world, because this is a disease which nature has not bestowed upon us in any manner, but we have brought on it ourselves, and predominantly because of a single vector, and that vector is the cigarette. And predominant cause of COPD worldwide is smoking, although in our country there are certain other important causes, especially the use of biomass fuel used for cooking, especially in rural and semi-urban areas. And you have ladies cooking for 5 to 6 hours a day, three different meals, or with biomass, and they're inhaling that smoke in poorly ventilated environments. And that is what gives rise to this disease in non-smokers in our country. Sorry. So, is it a major health problem? And the answer to this is yes. It is a 4th leading cause of death worldwide, and in another less than 10 years, it is predicted to be the 3rd leading cause of death. And you can see the reason why. A huge number of smokers worldwide, and this is projected to increase significantly as nations and communities become richer. The use of tobacco and smoking is directly proportional up to a stage to the level of economic development. And the 2 countries which will contribute the largest number of patients to this pool is China and India, because we have the largest population in the world, and which is also improving economically, so people are able to smoke more. And I just mentioned to you certain non-smoking causes, such as the use of biomass fuel. And needless to say, I don't have to emphasize what is happening in terms of air pollution, especially in our country, with the increasing use of cars and automobiles and poor checks on their quality. Now, the other disturbing feature about COPD is that if you compare it to other very common diseases like cardiovascular disease or coronary heart disease, you can see that the age-adjusted death rates in all these diseases have decreased over a period of time. But it's only COPD where you can see there has been a significant decrease in the age-adjusted mortality as opposed to other diseases. And obviously this huge burden of disease imposes a huge amount of costs to the community. And if we look across all respiratory diseases, and the cost involved with managing the highest by far is in managing COPD. And the reason behind this is a large number of patients with COPD need hospitalization because of exacerbations. And all of us who have got experience of managing these patients know how troublesome and expensive it is to manage these patients during their hospitalization. Now, as I mentioned earlier, the burden of COPD in India is predicted to increase enormously in the foreseeable future. It has increased very significantly. In fact, nowadays we see more patients in our OPD with COPD gradually than with the other very common disease of asthma. And this is really due to the reason I enumerated earlier in terms of increasing smoking, use of biomass fuels, and increasing outdoor air pollution levels. Now, one of the biggest problems with COPD is that it is underdiagnosed. And this underdiagnosis was not only a problem in our country, but on a worldwide basis. And this has very important clinical implications, because underdiagnosis obviously is going to lead to undertreatment. And if we undertreat the disease, there is obviously going to be increased morbidity and mortality and increased is cost imposed on the entire healthcare system. Now this is one of the largest studies called the so-called NHANES study from the United States. This is a very old study, and this looked at about 20,000 people in the US and different age groups, and they were asked to comment whether they had COPD. So this is self-reported, and then the same group of people had a spirometry done to see how many of them actually have COPD. And you can see across all age groups that obviously the incidence of self-reported COPD increases with age because this is an age-dependent disease. But what is more important in this study, you can see, is that when spirometry was done across these age groups, in every age group, far more patients had COPD than they thought they had, just because they had not had spirometry. So you can see the problem. It's like the proverbial tip of the iceberg. So what we diagnose is perhaps a small fraction of what actually lies in the community. And this was a hospital-based study in India from 2 centers looking at the prevalence of obstructive lung disease, not necessarily only COPD. And you can see that these were patients who were admitted on a medical ward. So this is not respiratory disease, but medical diseases per se in a hospital. And all of them were subjected to spirometry. And more than 1/4 of patients in hospital at some point of time had obstructive airways disease. And more than 2/3 of these patients who were diagnosed to have obstructive lung disease based on spirometry never knew that they had an obstructive lung disease. So you can see again what the degree of underdiagnosis of this disease is. So how to actually diagnose COPD? Obviously we have to suspect it based on symptoms, and symptoms, the predominant symptoms are cough, sputum and breathlessness, and this could be episodic or on a more or less continual basis. And then have these patients been exposed to any of these risk factors? For example, were they smokers? Have they worked in any occupation where they were exposed to a lot of environmental pollution, or any other form of indoor pollution, like I said, the use of biomass fuels? Once you have this background, then you can confirm the diagnosis with the use of spirometry, which again is a very underutilized tool, as I will talk about it. And what spirometry helps us to do is to not only diagnose asthma, but COPD, but many times rule out asthma, because usually, as we all know, in asthma there is a good degree of reversibility, whereas in most patients with COPD there is not that typical reversibility. Now, this underutilization of spirometry can be illustrated by these 3 different patients. You can see this patient has come to the OPD, this patient is on non-invasive ventilation, and this patient is intubated and ventilated. And what is common to all these 3 patients is that they had bad COPD, as you can surely make out, but they had had no spirometry prior to these 3 events. So you can see this spirometry was underutilized even in the West. And you can see the predicted FEV1 is only about 25 to 30% in these 3 patients. So they had severe COPD, and yet they had never had any spirometry. So the basic diagnosis on spirometry of COPD is when the FEV1 FVC ratio is less than 70%. And this is the sort of flow volume loop. We can see this is the normal flow volume loop, and as patients develop airflow obstruction, there is a slight scooping out or concavity of the expiratory flow volume loop. And as the disease gets more severe, this concavity is much more pronounced. And when you look at a flow volume loop, it's very easy to actually just see and say if somebody has obstructive lung disease. And why is spirometry important? It is not important only from the diagnostic point of view, but it also gives us a very good idea in terms of the prognostic implications. Because in this study of nearly 5,500 patients, you can see that based on spirometry, what was the survival of patients as you followed them up over a period of years. And you can see the more severe the disease is, ranging from minor symptoms to mild COPD on spirometry to more moderate and severe COPD, you can see that the proportion who survived were gradually less and less. So it not only gives us a diagnosis, it also gives us a feel of what is going to be the likely prognosis of these patients. So what I would suggest in terms of spirometry is If a patient has any symptoms but the X-ray is normal, still think of doing a spirometry. When the respiratory history is very long, always please do a spirometry. If a patient has smoked or is smoking and has got minor symptoms, think of doing a spirometry. Don't only think of an ECG. Because as you recently, the American Heart Association has also recommended that the resting ECG in most patients who come for routine checkups is a waste of money and time. And yet you will find patients with COPD having multiple ECGs but not a single spirometry report with them. There's so many patients I see. So this is just because of our mindset, I think, right from a medical student days, because we were exposed to ECGs a lot more than we were exposed to lung function testing. And so the way you think of blood pressure and blood sugars, for hypertension and diabetes, please think of spirometry for asthma and COPD. So now we move to how do we actually manage these patients with stable COPD. In the past, there was a lot of pessimism about this disease because most of us felt, oh, the patient kind of brought on this disease on himself or herself by smoking, and there is really not much treatment available. So what is the point of putting our mind too much to this disease and let the patient suffer? So there was this sort of huge pessimism. But gradually over the last 2 decades, although things are not ideal, there is now some ground for optimism that you can help these patients. And there are very robust evidence-based guidelines, mostly as per the GOLD guidelines, as we all know, which look at the management of COPD. So obviously our aims of treatment are manifold. We need an early diagnosis so that we can intervene early. The patient is interested in control of symptoms because this is what impacts their quality of life the most. A patient with COPD is breathless to do usual activities of living. So they need control of symptoms and improvement of exercise tolerance so that they are able to do more. And one of the most important events which occur in the natural history of COPD are these exacerbations. Because exacerbations lead usually to hospitalization, which impacts the patient in terms of financially and also health-wise. And you can see that how the natural history of COPD is, each exacerbation brings down the baseline. Once a patient gets over an exacerbation, you can see is never at the same level at which he was earlier. So each exacerbation leads to a reduction in their baseline lung function, and this eventually will lead to severe disability and even death. So preventing and managing exacerbations at the earliest is one of the key goals of COPD management. And as per the GOLD guidelines, you can see COPD has been categorized into mild, moderate, severe, very severe, based on their post-bronchodilator FEV1. And this in one single slide encapsulates the outline of the management plan of COPD. Right at the beginning, the most important management initiative is to ask the patient to stop smoking if they are still smoking. And of course, influenza vaccination also right at the beginning of these patients. And then as the patient has more and more severe disease, we keep on adding plans in terms of management, bronchodilators, steroids, inhaled steroids, pulmonary rehabilitation, maybe theophylline, long-term oxygen therapy, sometimes surgery and sometimes non-invasive ventilation. So if we now look at the definition of COPD, which is now sort of being proposed, it's a preventable and treatable disease. So anything which is preventable, that means we can intervene and do something about it. And it is treatable, so we should not lose hope and say we are dealing with a hopeless disease. This is characterized by airflow limitation, which is not fully reversible. But when they say it's not fully reversible, they don't mean it is irreversible. So there is some scope for reducing the degree of airflow obstruction. The airflow limitation is progressive and it is associated with an abnormal inflammatory response. So we have some anti-inflammatory drugs because this is an inflammatory disease, although the inflammation is not the same as the inflammation in asthma. In asthma, you have an eosinophilic inflammation predominantly. And the eosinophilic inflammation is amenable to treatment much more because of inhaled corticosteroids. A non-eosinophilic inflammation, maybe a neutrophilic inflammation to some extent, is not totally amenable to currently available therapy. But there are some therapeutic interventions which are in the pipeline.